Good morning and welcome to today's webinar, a new topic, Medicare Basics, What You Need to Know, presented by Mr. Mark Trent of Medicare Supplement Services. My name is Jeff Stauffer, Community Relations Director with Elville and Associates, and I'll be moderating today's event. So how this will work today, if you're new to our webinars, if you are, welcome. We're glad you're here. And if you're a returning attendee, as always, welcome back. So you as the attendee are in listen-only mode. However, if and when you have questions, please note them in the questions panel on the right-hand portion of your screen, and we will take all questions throughout the presentation and also leave time at the end to address them as well. Your questions really help the presentation, add value, they help others learn, so please don't be shy in posing your questions at any time. For CFPs, CPAs, and various other professionals on today's webinar, as always, you may receive 1.5 continuing education hours for attending. And per my attendance records requirements, please email me your ID number if I don't have it already. And for CFPs only, I also must have the last 4 digits of your social security number as soon as possible so I can submit your CE hours for approval, which I'd like to do by tomorrow. Everyone will also receive a post-webinar feedback email right after the presentation, and we ask that you please just take a couple minutes to fill out this simple survey, offer us your feedback about the presentation, and we read and value every comment. For example, we found this topic was requested many times from our attendees, and so we made arrangements to make this happen. So we appreciate all your comments and are looking forward to having Mark share his presentation today. So here at Elville and Associates, through planning and elder law techniques, our attorneys work every day with families and their loved ones with the ideals of client education, collaboration, and compassion in mind. And we're always available for consultations to discuss your family's needs and look forward to being a resource to you in any way. So I have the pleasure of introducing today's presenter, Mr. Mark Trent of Medicare Supplement Services. Mark was the featured presenter at Elville and Associates 2017 and 2018 annual client events, and we stayed in touch with him over the years, and he's been a valuable resource for our clients. His presentations were really well received, very clear, making a very complex subject very clear, and very engaging, and I think you'll probably see that here today. Mark sold health insurance policies to self-employed people on the individual market for years. Later, he recognized how complicated Medicare was through his own family's experience and decided seniors needed help and guidance on how to not make costly mistakes. For 22 years, his business model has been to educate seniors about Medicare and how it works, find the best and most appropriate Medicare supplement plan for them at the lowest rate, and facilitate enrollment in a Medicare Part D prescription drug plan. For seniors, this means peace of mind regarding a very complicated and important subject. So Mark, thank you for being here today and offering this presentation. We appreciate your time. It's good to see you again, and I will turn it over to you.
Great, thank you, Jeff. I appreciate your allowing me to do this, and thank you to the Elville organization. Folks, I'm going to assume that the reason why people are on right now is either they're approaching 65 and the eligibility for Medicare, or you're already on Medicare and have some concerns, or you are past Medicare eligibility, meaning you've just continued to work, and now you're looking at retirement. And I'm probably sure in every situation, you're confused because Medicare is confusing. And what I'm going to try to do is unconfuse things, is basically to eliminate some of the concerns and the doubts that are involved in health insurance, because health insurance is a big deal if you're becoming older, as you all know. Now, we're going to go through a number of different things. We're going to be going over the ABCs and the Ds, like what are all these letters about? And a little bit of a history about Medicare, which is where I want to start at the moment. Then we're going to move on here. Medicare has been around since 1960. 1965. That's when the bill was passed, and it actually started in 1966. But you have to say to yourself, what was there for seniors prior to 1966? The answer is, if you are had retired, let's say, and this is 1950, and you just left work, and now this is your golden years sort of thing, and you've worked for 50 years, and you have health issues, what did you have to look forward to in terms of health insurance? The answer to that is you didn't. Basically, only a few companies would offer health insurance past having worked there. After that, you're pretty much on your own. And even back then, health care was expensive. Now, the United States has been battling with itself over health insurance since 1935 in terms of an attempt at universal health care, which actually started in 1935 when the Roosevelt administration tried to have health care for all built into the Social Security bill. That didn't work out. Even back then, the conservative elements of our world didn't want to have anything to do, didn't want to have Medicare, or rather a government involved in healthcare. So that didn't work out in 1935, but then the next president up was Truman, and he attempted it twice to get healthcare for all, which didn't work. The next president after that was President Eisenhower, and for 8 years that wasn't an issue. They didn't have anything to do with it. And then the last president up after that was Kennedy, and Kennedy amended the whole concept to 65-year-olds and older. And of course, we all know what happened to John Kennedy. And then, of course, Lyndon Johnson did get it put through Congress. And then, as a matter of fact, just a point of history here, that's when President Johnson actually flew down to Independence, Missouri on Air Force One there and signed the bill with President Truman in attendance. And the first Medicare card went to Harry Truman. The second one went to Bess. But since that time, then, millions of people have been on Medicare. Today, you're talking upwards of 64 million people are covered by Medicare and growing. Lots of people because of COVID. I've been doing this business now for 22 years. I mean, the health insurance industry. But when it comes to Medicare itself and Medicare supplements, in the last couple of years in particular, it's been growing because people are retiring. They recognize that COVID meant you might not have as long to deal with these things. So it's been kind of a boon for my industry. Now, I'm going to move over here to a completely different screen here and start going to the basics. The book you see there, Medicare and You. Hopefully you guys can see this. Medicare and You is sent out to millions, all Americans are on Medicare right now. The odd thing is they send it to you after you're on Medicare already. It would make more sense if they send it to you before you get on Medicare, but hey, it's the government. Now, I contend that this is the least read book in America because when you do open it up, you find it thoroughly confusing. And so that's kind of like written in Latin. So let's get beyond that and get to the common sense stuff here. First and foremost, the A, B, C, and the D. What is Part A? Part A is your hospital, your hospice, and skilled nursing part. Think of Part A as inpatient coverages. All right, that means overnight. That's the big stuff. That is also your entitlement. This is what you have been paying for all your working life with your FICA taxes. So Medicare Part A, when you read that book, if you can find it in that book, there's a little sentence in there somewhere that says there is no cost for Part A. That's completely not true because you pay for it every time you've ever filed your taxes. Now, when it comes to Medicare Part A, that's just the inpatient part, but Part B, that's the outpatient coverages. That's the stuff we all use. Doctor visits, tests, labs, emergency room, physical therapy, outpatient surgeries, chemotherapy treatments, radiology, durable medical equipment, anything that you can think of essentially that's not overnight. And when you link the two together, Now you've got Medicare Parts A and B together. Now you've got inpatient and outpatient offered to you. And now you've got a really nice health insurance policy. And on its most basic level, original Medicare A and B is just health insurance. But like any health insurance you've ever had, you've got deductibles, co-payments, and co-insurance. That's called out of pocket. And Medicare is no different. In fact, it's quite significant, the out of pocket, which is why we have these things called Medigap plans to fill the gaps, because a senior doesn't want to have to go find the money to fill the gaps. Now, so A and B is what's called original Medicare, and it's got gaps in it. And we're going to get to the gap fillers in a minute. But then there's something called Part C and Part D. Original Medicare A and B has been around since 1966. Medicare Part C and D is relatively new. Those have only been around really in their current forms since 2006. Medicare Part C, you've probably heard of. Don't know it's called Medicare Part C, but they're called Advantage plans. If you happen to see certain personalities on TV hawking these things, Advantage plans are relatively new and they're totally different from a Medigap plan, and we'll get into the differences later. And then Medicare Part D, the drug program, and you need to understand also about the drug program, prior to 2006, Part D did not exist. You were on your own when it came to prescription drugs. And of course, it came into being, and it is also thoroughly confusing, which we'll get into that as well later on. Now, let's talk about money a little bit. We know that Part A doesn't cost you anything. I didn't say that about Part B, though. Oops, here we are. You've got premiums for Part B. Part B, the typical premium is $170.10. We have what's called a standardized level. Now, Part A, I said, is free. Well, the truth of the matter is we know we pay for that. But if somebody has never contributed to Social Security, then Part A actually is not free. Or perhaps you have, say, a parent that comes from another country to live with you, and that person's never contributed to the Social Security system, then Part A by itself really is about $473 a month. Now, vast majority of Americans work, so they never know that. Now, Part B, the basic standard level is $170.10. But that's just the starting line. You see, the government reviews our income. We are means tested. And what the government does is it looks back at our modified adjusted gross income every year. And they look back 2 years. So this is 2022. And if you're coming on here in the year 2022, and you filed your federal income tax, which you're supposed to, they're going to be looking at what you filed for your federal income tax. And when I say modified adjusted gross income, that means all your deductions are taken out, plus any tax exempt interest. That's the bottom line of your federal income tax, right? Now, and if you are above a certain level, then IRMAA kicks in, income related monthly adjustment account. Now let's go to another thing here, and here's how the money stuff works. If you're filing jointly with a spouse and you're showing after all the deductions are taken out less than $182,000, then yeah, it's $170.10. On the other hand, if you are considered to be a higher income earner, and now let's say you're between 182 and 228,000, now you're looking at $238.10 a month. The difference is basically a surcharge. It is what I call it, a tax. If you're between 228 and 284, then you're looking at $340.20, 284 and 340, $442.30 a month. And by the way, this is if both husband and spouse are on Medicare, that's each.
That's not just for the group. Then they're between 340 and 750 grand. It's $544.30 a month. And if you're really raking in the dough and you're making over $750,000 after taxes, then $578.30 is what you'd be paying, which probably isn't too much of a hardship. But anyhow, you can see here by the filing joint versus filing individual. If you're looking at the filing individual, then you're in the same boat. And if you're showing less than $91,000, then you're going to end up having to pay $170.10. And of course, it goes on down the line. So it really boils down to how good you are at making money. Now, when it comes to supplements, so far we know this: Medicare Part A and B, inpatient, outpatient. And we know that for the vast majority of us, Part A doesn't cost anything, but Part B does cost you something, right? I want to point out one more thing about Part B, and this is an ongoing situation right now. Part B last year in 2021 was $148.50. Suddenly, and they always reevaluate this stuff at the beginning of every year, suddenly CMS, that's the government, raised the premium to the $170.10 standard level. And it's because of one single thing: a drug. Certain medications are covered by Part B. And one of them was supposed to be a medication for Alzheimer's. That medication was supposedly going to cost $56,000 a year. And Part B was going to be paying the majority of it. So the government on its own, CMS rather, the Centers for Medicare and Medicaid Services, on its own decided to raise the rates for everybody $22. Right now, there's a fight in Congress over that to get that amended and changed back, because not that many people, that drug has really not even been approved by the FDA. And they want to get it back down to a more reasonable level, back to like $150 or something like that. But that may, in other words, that standard level may yet be changing this year. We don't know. It's ever changing. Now, about supplemental policies. You know about A, you know about B. They're linked together. When you link them together, just think of it as a unit. AB, inpatient, outpatient. Who doesn't want to have both, right? And now you've got gaps. Well, let's talk about what those gaps are first. We're going to go down here. Here we are. Part A, hospital. If you didn't have any kind of a supplement, if you had nothing to help you here, you're looking at a $1,556 hospital deductible. Now, that's not per year. That's per 60-day period. Now, what does that mean? It means if you're in the hospital, let's say in June for 4 days, and then you get out and you haven't got any kind of a supplement, you have to pay the $1,556. But let's say now you go back into the hospital for whatever reason, say it's October, and it's obviously been more than 60 days since the last time you were in the hospital. Well, now you have to pay $1,556 again. So in other words, you could end up having to pay multiple hospital deductibles in a year if you don't have something to fill that gap for you. Then the 61st day through the 90th day, if you're in the hospital continuously, and let's face it, because of COVID, a lot of people have been in the hospital for a long period of time. And from the 61st day through the 90th day, all of a sudden now you're paying $389 per day past the $1,556. And if you're still in the hospital up to the 90th day, on the 91st day, then they start charging $778 more per day. You've got some real financial exposure here if you don't have a supplemental policy. Now, if you have a supplemental policy, they're called Medigap plans. They fill the gaps and they supplement your potential loss. So here's something to learn. And that the learning is that if you supplement fills the gaps and it supplements your potential loss.
which means they're really talking about the same thing. So when you hear supplement and when you hear Medigap, it really is the same thing, only most people haven't got a clue that's what it means. But they really are selling Medigap plans. Now, the Medigap plans are made by the government, and that's where things get really kind of weird. Now, before we go on, I'm going to talk about Part B. Part B, you've got a deductible of $233, but that's once a year. It's an annual deductible. And then it's also an 80-20 plan. That's the expensive part about Part B. Once again, if you don't have a plan and you end up having to pay for Medicare Part B can end, if your 20% can end up costing you a small fortune. And there's also one other thing called excess charge. Excuse me a second. I apologize because there's a phone that kept going off behind me there. You pay an excess charge. Now, if you have a plan, and and just to make things thoroughly confusing, there are 11 different possible plans. It says here, what's a supplement? You'll see that it has lots of different possible plans. Now, we talked about parts A and B, but these are plans. Plans and parts are not the same thing. There's plan A, B, D, G high deductible, K, L, M, N, F, and F high deductible. Now here's the crazy thing. All the plans are made by the federal government. For those of you that are approaching Medicare, for those of you who are on Medicare, then you know full well you've been advertised to mercilessly by the insurance industry. The insurance industry is all screaming at you saying the same exact thing. Buy my plan G. G is the best. And the answer and the truth of the matter is that's not the case. G is a plan anybody can buy from any company. And since the government actually makes the plans G, they don't sell them though. And what the government does though is it contracts it out to private enterprise, and private enterprise basically says, oh, okay, so G is G, I mean the coverage is the coverage, but we're not regulated as to how much to sell it for. I mean, you can sell it for anything you can get out of the market. Yes, that's the case. So when you hear about companies like United Healthcare, Care First, Aetna, Cigna, Mutual of Omaha, Thrivent Financial, Western Catholic Union, tons of different companies, they're all selling the same thing, but there's no regulation for how much they sell it for. And that's where an agent like me comes in. I'm a broker. My job is to be appointed to all these different companies. And if you want a plan G and you want it from a company called Mutual of Omaha, it's no different than it is if it's a plan from a company called Cigna. Now, let me give you an idea about rates for a second. We know that these companies can do various things. I'm going to just give these, what you can't see here is I have what's called rate sheets in front of me. Rate sheets that only you would not be able to find, by the way. You can't go on the internet and find these things. It's for agents like me. Let's say you're a 65-year-old female. You're just becoming eligible for Medicare, let's say in June, and you want a plan G. Plan G, which by the way is today's Cadillac plan. It's the best plan anybody new coming onto Medicare can get. A company called Cigna, it will sell that plan for $183.10. On the other hand, there's a company called Mutual of Omaha. They'll sell that exact same plan for $158.60. Oh, and one other thing, you might qualify for what's called a household discount. A household discount means if you're simply living with somebody who's 60 years of age or older under the same roof for more than 12 months, then you qualify, like your spouse. And if that were the case, then Mutual of Omaha would give you a 12% household discount, and no, your spouse doesn't have to be on Medicare, and it would drop to $139.57. On the other hand, you could go to Aetna, which doesn't require that you have to live with somebody. This one would be sell it for $144.94. Basically, it all comes down to this. What company is selling the plan that I want at the lowest possible price? Now, all these different plans. The Cadillac of all plans prior to 2020 used to be called Plan F, as in Frank. For those of you that are on Medicare right now, if you were on Medicare prior to 2020, then you could still sign up for Plan F. For anybody coming on to Medicare after 2020, you can't get it. And the reason why you can't get Plan F was the Cadillac of all plans. No deductibles, no co-payments, no co-insurance, no nothing. Everybody loved that plan. But why did the government shut it down? That's because we loved it to death. Meaning so many people would simply go to the doctor at the drop of a hat because they had no out of pocket, no $20 co-payment, no nothing. And so everybody loved that plan. So the government says, people are going to the doctors too much. We have to have some skin in the game, so we're shutting down Plan F. For anybody that's new coming on, though, the best you can get right now is Plan G. That's the next top of the line. And the difference between a G and an F is the fact that you do have a deductible on Part B, which is a $233 deductible. So you do have some out of pocket, but that's it. Beyond that, they're identical. Now, why are there 11 different plans? Well, it's thoroughly confusing and frankly unnecessary. But a Plan A, not a Part A Plan A is really more for somebody disabled under the age of 65. B and D, you never even see in state of Maryland. G and G high deductible, they're popular plans. The G high deductible, most people don't want because it is high deductible, meaning you have to pay $2,490 out of pocket first before it even kicks in. And then on top of that, you still have a $233 deductible on Part B. But anyhow, is the premium low? Sure, it's real low. Then there's K and L and M. Again, almost nobody buys those because there's lots of exposure, financial exposure in those. And then there's N. N is super popular because there's a little bit of out of pocket, but very good premiums. And then again, for the people that are older than prior to 2020, then there's Plan F and Plan High Deductible F. All right, so you got all these different possible plans. Now, what you really should understand here, you want to understand is how these things actually work. But before we get there, I want to make one really important point. When you're fully on Medicare, your health insurance company is the Centers for Medicare and Medicaid Services. In other words, it's Medicare that is the boss. When you file a health insurance policy, you go to any Medicare provider, literally anywhere in the United States, doesn't matter, Medicare is everywhere. When you go to that doctor, the doctor sends that claim not to a supplement company. Let's say you're set up with your Medicare supplement through Aetna. It doesn't go to Aetna or it doesn't go to United Healthcare. It goes to CMS, the Centers for Medicare and Medicaid Services in Baltimore. They adjudicate all claims. So if somebody has, let's say, a $1,000 MRI, then Medicare will evaluate that claim to see that it is legit. And if it is, then Medicare will pay its 80%. The other 20%, if you have a supplement, will pick up the rest of it. So you end up paying nothing. But the point is, who makes the decision here? Medicare does. Now, if Medicare denies a claim and doesn't think it's a valid claim, then your supplement companies will do nothing. If Medicare pays, the supplement companies, no matter who they are, will pay. If Medicare denies a claim, your supplement company will do nothing. They just follow suit. So who controls the whole issue of what is really covered? Medicare does. So if you ever have a question about whether X is covered, some kind of procedure is covered by Medicare, then don't call your supplement company. They won't know. They are not your insurance company. Your insurance company is Medicare itself, and your Medigap companies just fill in the gaps. That's all they do. They don't think. They don't underwrite your risk. Medicare does. So that's your entitlement. That's where the government really controls the whole issue. Now, I want to show you what's called an outline of coverage. I hope you can see this. I'm going to move to a completely different screen here now. This is Plan G. And you'll notice at the top here, it says, whoops, it says Part A, Hospital Services and Benefit Period. You'll notice there's 3 columns here: what Medicare pays, what the plan pays, and what you pay. Everybody likes the you pay column. You'll notice how if somebody's hospitalized, they have a $1,556 deductible. Medicare pays all of that except the $1,556. So it's a $10,000 or $20,000 hospital stay. Medicare pays all of that except for the $1,556, which when you think about it is not all that bad. Then the G plan picks up the $1,556 for you, and you pay nothing. The $389, if you're in the hospital all that time, the Medicare would charge you, but your plan picks it up and you pay nothing. The $778, plan picks it up, you pay nothing. Basically, your hospital stay on a Plan G cost you nothing. Then there is skilled nursing. Lots of people don't understand, but Medicare does not cover us after a certain point for long-term coverage, long-term care. We'll get into that in a second here. But it will up to 100 days. It says here that if you are in some sort of a long-term care facility, the first 100 days, the first 20 days rather, is paid for by Medicare, and you pay nothing. But the 21st day through the 100th day, the government will pay, Medicare will pay all but $194.50, but the plan picks up the other $194.50 for you, and you still pay nothing. But after 101 days, folks, we're on our own. That's when we have to deal with Medicare, with long-term care plans. So if you don't have a long-term care plan now, you might want to consider it, because unless you've got kids to take care of you, and a whole lot of people may have kids, but they may not want to be taken care of by the kids, then you might want to consider long-term care. In which case, getting a long-term care plan is very much in your best interest. Talk to the financial services guys. This is what they do. And it may very well be in your best interest. Now, the next Part B here, you'll see here where it says here, in terms of outpatient services, basically Medicare is saying that you have a deductible to be met first, the $233 deductible once a year. Any kind of an excess charge, and I want to make a point about excess charge. Excess charge is where, if you can find a doctor that does not take assignment, and the vast majority of doctors take assignment, like 96%. But if you can find a doctor that does not take a Medicare assignment, they'll take what Medicare gives them, but then you can ask for an additional 15% of you. Now, that rarely ever happens, but if you had a Plan G, it gets picked up automatically anyway. And then you'll notice here that basically everything on Part B is zeros, because once you've passed the 233, you're finished. And the last thing is on a Plan G is foreign travel. For those of you who may be traveling overseas, Medicare is not overseas. Let's say you're in Italy and you have a health issue that's got to get you back home. Well, what happens is the plan is not, this part of the plan is not about fixing you. It's about repatriating you. It's about getting you back to the United States. In which case, then it's an 80-20 plan. It'll pay up to 80% of whatever that charge is, and the other 20% is what you have to pay, and then you have a deductible of $250. But the maximum is up to $50,000. So basically, it's like a ride back on a jet back, let's say, to the United States. All right, but that's where Medicare is. It's certainly not going to be overseas. But this is not the same thing as travel insurance, which is what you should get, which is completely different. All right. Now, we've talked a little bit about the supplemental policies. We talked about A and B, the gap fillers, Medigap plans, and a little bit about the cost and stuff. Now, let's go down here to drugs. I know full well people have got lots of questions about drugs. Jeff, at this point, do we have any questions? Jeff?
Thanks, Mark. We do have a few questions. I think now would be a good time to try to get those addressed. Thank you. Let's go ahead and pull those up. First question, are Medicare Advantage plans and Part D plans allowed to change their formula mid-year?
Are you talking about the medications? Are you talking about just the whole plans? If you're talking about the medications, yeah, they can. If you're talking about how the plan works, no. Meaning in terms of medical care. The thing about Advantage plans, and we'll talk about that a little bit right now, is that they're private industry. And private industry gets to make its own decisions about what's covered or not covered. Medicare, Medigap plans are tied to original Medicare, and all those decisions are made by CMS, Medicare. But when it comes to Advantage plans, they make their own decisions. And most of the time, the Advantage plans are meant to be managed care, which means they want you to go to their doctors and their facilities to get referrals and all that. But when it comes to the medications that are built into their plans, there's Medicare Advantage PD plans, that's prescription drugs, or there's Medicare Advantage plans, and then you get a separate prescription drug plan, which in my mind is a better idea because those are tailored to that individual. If you have an MAPD plan, then you have to deal with whatever their drug program is, and you can't change, and they can change it, and you can't change anything until the next open enrollment in the fall. I hope that begins to answer the question.
It does, thanks. If there's any additional follow-up, I'll let you know. Thank you.
Yeah.
Next question is, if you're going to be moving across state lines, say from DC to Maryland, do you have to change your supplement plan and your Part D and your Advantage plan? What is the time window for doing this? Can you do it before your move, or do you have to wait until after your move?
Okay, two different things. Medicare, Medigap plans. They are federal plans. You can move wherever you want. It does not matter. You want to go to Utah, feel free. And there's nothing to do. It just follows you wherever you go, period. Now, the rates may change. In other words, once you've established, let's say, a new home, let's say in Utah or something like that, then the rates may very well go up or down, probably down. But so when it comes to Medicare and Medigap plans, you can go wherever you want to go. It doesn't matter at all. They're federal plans. On the other hand, Medicare Advantage plans are not that way. Medicare Advantage plans are tied to your zip code. And if you move out of the service area of your Advantage plan, then you have to change. And you can change like mid-year if you have to find a plan that actually covers that area. And they give you like 63 days to make a decision about what you want to change to. So in other words, those are very much tied to the area of where you've set them up. That's kind of the downside of those things. You can't travel anywhere near as well as you can with a Medigap plan. Same thing with Part D drug programs. If you have a Medigap plan, which doesn't matter, but you also have a drug plan and you move down to South Carolina. Well, what worked here in Maryland for your Part D drug plan may be completely out of the service area of the plan that you're on in South Carolina. So you can change, because we're allowed to move, you can change at that time to get another plan that services that area. So now, when it comes to what you referred to, then I think is the open enrollment period in the fall, and you have an Advantage plan or a prescription drug plan, that is what they're for. You can change a Medicare Gap plan any time of the year. On the other hand, Advantage plans or drug plans must be changed, if you're not moving, that is, between October 15th and December 7th every year. It is the only time to do it. If you don't do it, then you're stuck with what you got.
Okay, let's try another one. I retired 7 months ago from the federal government with Fed BCBS, I guess that's Blue Cross Blue Shield, and need to decide whether to pick up Part B for my wife and me. We are in our 80s. With IRMAA Part B is very expensive for the two of us. Any advice or suggestions? This might be a personal situation here.
Yeah, if you're talking about changing over to a Part D plan, I think you said, or was it a B? I forget.
Part B.
Pardon me?
Part B.
Well, I think what you're talking about is picking up Part B, but then getting a Medicare Gap plan. Here's the deal. If somebody's been on Medicare for more than 6 months, and then they want to go get a Medicare Gap plan, they're going to have to prove insurability. That means they're going to have to go through your pre-existing health conditions first. You can change a Medicare Gap plan any time of the year, but you have to also prove insurability. If you have high risk health issues, you cannot change. When somebody's in their 80s like this, and yes, I know your plan is expensive, I can tell you right now, that's still your best bet because they can't cancel you, and trying to move would be very difficult to do. I would say stick with what you have.
Okay, great.
Especially a government one.
So let's try one more for now, and then we'll move on. Do have a couple more, but we'll keep moving with the presentation. If we travel overseas, is it recommended to purchase travel insurance through our travel agent, for example, to cover an overseas ER visit?
Yes, absolutely. As I'd mentioned before, Medicare Gap plans only cover so much. Really, it's more about getting back to the United States. But when it comes to being out there and having like a bicycle ride in near Paris and you break your leg or something like that, then yeah, travel insurance will take care of something like that. And so I would recommend anybody get travel insurance because they're really they're really typically high deductible plans. They're way better than nothing. And they're not all that expensive. So I would get travel insurance for the short period of time that you're typically there.
Okay. We have a couple of questions related to federal employees retiring. Do you want to address those now, or do you want to move on for now?
Let's move on for a little bit first.
Okay. Thank you.
Let's talk about drugs. Everybody wants to know about drugs. Drugs. All right. First of all, as I mentioned before 2006, there was no such thing as a prescription drug plan. And I want to point out also that your Medicare Part D drug plans are voluntary. To this day, you do not have to have a prescription drug plan. But if you do not get one, then try to sign up for one during an open enrollment period, you are going to get a penalty. And the penalty is 1% per month for every month you could have had it, on top of what your premium might be. So that could turn out to be like, I have friends who never got a prescription drug plan, waited 3 years before they finally decided to get one, and ended up having to pay something like 30% more on top of the premium. And when we're talking about the penalty, it is for life. It never goes away. I do recommend you get a prescription drug plan. The least, if you're in perfect health and you don't have any needs for prescription drug plans, at the very least get the cheapest one. It's $7.10 today. It's called the SilverScript plan, SilverScript Smart Plan. It's better than nothing. All right, it makes a lot of sense to have something versus incurring a possible penalty in the future. Now, about the Part D plans. So say that's, you see what I see on the screen here, it says it's not what you're used to. It's not what you're used to. When it comes to the Medicare Part D plans, they are in fact tailored to the human being. And that means there is no such thing as one size fits all. It doesn't work that way with Medicare Part D. And what happens is there is a database. The database is medicare.gov. Keep that one in mind, folks. Medicare.gov, that's an important website for you. Go to medicare.gov and you can enter into the database, medicare.gov, precisely the medications you're taking. And I do mean precise. You want to tell the database what the milligram is of the medication, what's the real name of the medication, meaning if it's generic, give it the generic name, whether it is a tab or if it is a pill. In other words, be very, very specific. And when you put in, like, say, your 4 medications, then what the database is going to do is it's going to go find the plan that's in your area that has the best deal, the best buy into the summary of the medications you happen to take. And oh, by the way, the prescription drug plans are based upon the zip code area in which you live, and typically every area has about 40 different possible plans, just to make things confusing. But what you want to do is you want to find the plan where you pay the least amount of money out of pocket at the drugstore counter. It's not about the premium. It's about what do I pay for the drug itself. And that's what the database is designed to do. Now, Medicare, when this thing was set up, and the Democrats and Republicans fought like cats and dogs in 2003. And what was not allowed was to use the clout of 60-something million people to actually negotiate the rates on the drugs. It was set up so that the individual prescription drug companies had to negotiate every year with the pharmaceutical industry. So in the fall, you hear about this stuff called open enrollment. And open enrollment is designed to be used to change your prescription drug plan every year because the plans change on us. So in other words, you have say you have a prescription drug plan, you've got 4 medications, it's working great for the year 2022, and you don't want to change anything. Why would you want to do that? Because the plan itself has to renegotiate at the beginning of the year for 2023, and what was an affordable medication, let's say in 2022, suddenly becomes a whole lot more expensive. You don't understand why they charge so much more money for this particular med. That's because you didn't take the time to review what the best plan was for 2023. When it comes to the Part D plans, they are confusing. There's no question about it. But the only resource you have really is Medicare.gov. You could go to a Department of Aging if they're open. You could go to some nursing homes do this as a courtesy. When I set clients up on a Medicare Medigap plan, I do set them up on a drug plan as well, using the government's own database. But you're probably going to find this surprising. I don't recommend, though, that you buy a prescription drug plan from an agent. I don't charge for that, by the way. I don't get paid anything to set up a drug plan for a client. But the reason why I don't sell them is because if I'm appointed to some company, let's say I'm appointed to Humana, it doesn't, and I'm obviously wanting to sell the Humana prescription drug Part D plan to get a commission, but it doesn't mean that that plan has got a good buy into the medications you take. So the only ethical way is to use the database, Medicare.gov. It's the only source there is. Now, there's 2 ways of doing that. Well, 3 ways. You could do it yourself by simply going to Medicare.gov, but it is confusing. You could use an outside resource like myself to do it for you if you're my client for Medicare Medigap plans or somebody who does it on the side. Or you can simply call up, and this is be the smartest thing, call up Medicare, call up CMS. When you get your Medicare card, right on the back of your Medicare card is the telephone number for Medicare. And this is an important issue to understand about Medicare, it's there 24/7. You probably don't realize that. You always think of a government agency only being open from 9 to 5. Well, that's just not true. They're open 24/7. And so, and in particular, during the annual enrollment period, you really want to call in off hours because it's a real busy place. But you can call them and tell them precisely the medications you're taking. They'll go to the same database, Medicare.gov, and they'll set it up for you. So that's a resource. Anybody, you can use a telephone, you can do this. So when it comes to Medicare and medications now, if you're in the hospital, Medicare Part A covers your medications, period. If you're in an outpatient situation, let's say you have to, heaven forbid, to get chemotherapy treatment. That is a drug that gets pumped into your body. And let's say you go to the hospital. There, they pump in the medication, but you go home the same day. That's an outpatient service. That's Part B. Part B then will pay 80% of that $14,000 treatment. The other 20% gets paid for by your prescription drug, or rather by your Medicare Medigap plan. Okay, so there are drugs in Parts A and B. Now, Part D is the medications that you're taking at home. So look at it this way. If you're getting medications administered in a doctor's office, let's say somebody has rheumatoid arthritis and they get infusions of Remicade in a doctor's office, that's covered by Part B because it is doctor administered. Medications they're taking at home are self-administered. And that's what we're talking about when we talk about Medicare Part D, the drug program. All right, so a little bit of a history about Part D. Part D was enacted in 2003 and it went into effect in 2006. And Part D, seniors were on an average spending at least $2,318 at that time out of pocket. And then it was put together, by the way, by the House, the Senate, and the presidency was all Republican. They were all for a prescription drug plan for everybody. So they really set it up. And the companies have to negotiate every year. Now, the chief architect of the Part D program was steered through the House by, and you can look this up, by a guy named Billy Towson, who was a Republican from Louisiana, and he was the head of the committee that ran this thing. But anyhow, the interesting thing was after it got through Congress and everything's set up, he ends up leaving Congress to become the head of Big Pharma with a $2 million salary. So you can see how politics and the medication program are all kind of together. And here's the crazy part too. On Medicare Part D, we're not allowed to negotiate with the clout of CMS is not allowed to negotiate with 60-something million people. But the VA does. For you guys that happen to have, or ladies who happen to be veterans, if you want to get your medications through the VA, feel free because it's a good deal. Because they get to negotiate for the medications like Medicare cannot do, but VA can, which is really bizarre, I think. Now, when you get a Medicare Part D plan, it gets even more complicated in this regard. There are stages. Stage 1 is what's called an annual deductible. Stage 2 is the initial coverage. Stage 3 is the coverage gap. Yep, that gap is still there. And stage 4 is the catastrophic coverage. Now, the annual deductible. If you're taking medications that are tier 1 or tier 2, in other words, cheap generic medications, you do not have to satisfy any deductible. On the other hand, if you've got medications 3, 4, or tiers 3, 4, or 5, then yes, you have to satisfy a deductible. Now, some plans have no deductibles. Some plans have the maximum deductible possible, most of them actually, a $430 deductible. In which case then, let's say somebody's taking something like Eliquis. It's an expensive drug and it's brand name. And you're going to have to plow through that initial deductible. Then you get to the what's called the initial coverage. And then what happens is the majority of that medication is actually covered by your prescription drug plan. Not all of it, but most of it. And then there's the coverage gap. That's where you would end up having to pay specifically more for that medication, and because you're in the donut hole. And so you're paying more out of pocket for a few months, basically. And then you can finally get to the fourth stage, which is called the catastrophic coverage. And that's where the vast majority of the medication is completely covered by your drug plan, and you only pay like 5%. So most people don't even know this is the issue. Most people, if they're just taking cheap generic medications, will never know this. On the other hand, if you're taking combinations of medications that are cheap generics, or you start taking more expensive brand name type products, you're going to see it. And so that's how the thing was set up from day one, and it's been this way ever since. But that's why also you should review your prescription drug plan every year. It should not just let it go. Now, this is what you should do. Tips regarding Medicare Part D drug plans. Change or review the plan every year. Open enrollment is always October 15th through December 7th, and then your new plans begin January 1. And I want to point this out, don't sweat it. You got 7 weeks. For those of you already on Medicare, and you know about open enrollment, and you want to change your drug plan, and you don't want to forget about it, you just jump into it in the first 2 weeks. Basically, that means all hell's breaking loose at CMS. You'll have a hard time getting through. So what you really should do is just wait. Wait for a few weeks until, first of all, the people at CMS get more seasoned at what they're doing. And then, because there's a real onslaught that occurs. And then you've got up to 7 weeks, just so long as you do it before December 7th, you're good, you're golden. And then it starts January 1. The telephone number, like I said, is on the back of your Medicare card. And be very, very, very specific when talking to an agent there at CMS about what your medications are. Or you can just go to medicare.gov and do it yourself. And of course, I already mentioned the fact that you probably shouldn't buy your prescription drug plan from an agent. You should just use the database, medicare.gov, or the government itself, and they'll do it for you. And it costs you nothing, and you'll get the right thing. Now, about cost. Prescription drug plans can range anywhere in premium from $7.10 to $100. It all depends on the medications you happen to be taking. And there's one other little facet. Medicare Part B as in boy, as we talked about before, you are evaluated by the government, and you could very well end up having what's known as a surcharge. Well, Medicare Part D, as in drugs, also goes through the government. And because of that, you also could end up getting could get an increase, surplus, and surcharge rather. And if you're filing jointly, for instance, and you're showing that less than $182,000, then it's going to cost you nothing. There's no increase. So if your plan costs you $22 or something like that, then you're only going to pay $22. On the other hand, if you're considered to be a higher income earner, once again, if you're between 182 and 228, then you'll end up paying $12.40 on top of your premium. If you're between 228 and 284, then it becomes $32.10. If you're between 284 and 340, it's $51.70. You can see how it goes up and up and up. So if you're really up there, let's say you're somebody that's only taking medications, cheap medications, and you got a prescription drug plan, let's say like a silver script plan for $7.10, but you're a higher income earner and you're somewhere between 340 and say 750,000, then on top of that, you pay a surcharge of $71.30 added to the $7.10. So there's a potential for IRMAA to get you, again, your income related monthly adjustment amounts. So it just depends on how much money you make. So be aware of that. Now, Medicare Part C, those are the Advantage plans. I just want to point out about Advantage plans. They have their place. Where they work best is more in the urban centers. They are inexpensive. They're cheap, frankly. Their premiums are low. But what is not really well expressed by any of the advertisements you see on TV is what's called the maximum out of pocket. If you had something like a Plan G, God forbid you had cancer and you got that $14,000 treatment, your maximum out of pocket is $233 because that's your Part B deductible. On a Medicare Advantage plan in Maryland, all of the Advantage plans have $7,550 max out of pocket. What does that mean? That means, okay, I have to have a $14,000 chemotherapy treatment. That means the government will pay its 80% because that's Part B. But the other 20% you would have to pay. Your Advantage plan would not pay that until you've reached $7,550. Once you've reached $7,550, then it becomes 100%. But then again, it renews at the beginning of the next year. And once again, you get $7,550 to plow through. So while the premiums are very low and they really jazz it up by saying, oh, you're going to get free dental and vision, which is usually just discount stuff. The reality is when you get ill, you can end up spending a whole lot of money. When you least need it in your life, you end up spending a whole lot of money. Obviously, I'm not a fan of Advantage plans. I've seen too many people get hurt by those suckers. But they are, for somebody that's on a limited budget, it's something better than nothing. Because the cost of healthcare with just Medicare Parts A and B and having all those gaps can be extremely expensive, especially if somebody has some sort of a chronic illness. So that's Medicare Part C, Advantage plans, and what we really have, we have a limited amount. Depending, you basically got Humana, Johns Hopkins plan, Cigna HealthSpring, I believe, Kaiser Permanente. You know, those are pretty much the ones that are in our area. The farther out you go from the urban centers, there's less out there. So if you're really, you know, like Western Maryland or something like that, you're probably not going to find much in the way of Advantage plans anywhere, and end up having to go with Medigap anyhow. But like I said, for the urban centers, they have their deal. I mean, they're better than nothing. Let's put it that way, but not a whole lot. Now, fall open enrollment really is only for two things. It is really for Medicare Parts C and D, and that's because that's the only time of year we have a shot at making those changes. And for folks that have a drug plan already on Medicare Part D, you very definitely should look at it every year, and no matter what. Open enrollment, though, for your Medicare Medigap plan is any time of the year. It doesn't matter. In other words, I have clients right now who I see rate increases occur, and I'll tell you about that in a second here. Rate increases occur, and I'll call them up and say, hey, your rate has just gone up $40 from one year to the next. I have another company over here selling the exact same Plan G that you have. Would you like to move to that? Because you're going to be actually saving $70, something like that. But to do that, I have to ask about pre-existing conditions. Initially, when somebody first gets on Medicare, they have an open enrollment. It means come on in, no questions asked. In fact, it's illegal to put anything on an application about your health. But after 60 days, your health open enrollment goes away. And that means any company will look at your pre-existing health conditions. And if they consider you to be of significant risk, then they'll simply say, hey, stick with what you've got. You can't lose what you have. But we don't want to bring you on because it could cost us a lot of money. Now, they wouldn't say it that way, but that's what they mean. So when you're on a Medicare Medigap plan, and it works just great, but you've got a lot of health issues now, and you want to change, it's problematic. It depends on what the health condition is. Somebody's got minor health conditions, high cholesterol, hypertension, acid reflux, maybe even type 2 diabetes. It doesn't really matter. On the other hand, if the person's got a heart problem, cancer, lupus, Parkinson's, or something of that nature, you're stuck. You must stick pretty much with what you've got. But you can't lose it either. The only way you can ever lose a Medicare Medigap plan is if you don't pay the premium and you let it go for more than 30 days, then you're SOL. But that's how it works. All right. Jeff, you got any other questions here?
Thanks, Mark. We do. Great presentation, a lot of great information. Thank you so much for coming back to see us after a few years away from us. So we do have some questions. Now would be your time to get those last questions in. We had 11:15 as an end time. We want to try to respect everybody's time. So let's get those last questions in for Mark. So first question, should retired federal employees select the least expensive plan as their secondary plan instead of going with the G plan?
It depends. Meaning, when you're talking about government plans now, they have their own rules that are different from what everybody else has to deal with. And if they allow you to change, I guess, on a once-a-year basis during your probable open enrollment, and you're in pretty good health, sure, why not? But if you were to go to something like a Medicare, if you were to dump the government plan and then go to a Medicare Medigap plan, bear in mind, like I said before, that if you come down with some sort of significant health issue at some point and you want to change from one company to another, then you may well get stuck. But when it comes to the one through the government, I'm sure you have open enrollment every year. So I think I just look at it on a year-to-year basis myself.
Next question, UHC advertises an Advantage plan. Does that take the place of the federal health plan, or is that an Advantage plan?
I'm pretty sure it's an Advantage plan, but I don't know anything about it because, again, it's the government.
Okay. If I start a new medication during the year, will my Part D plan pay anything for that new medication?
Yes, that's a very good question, because whatever the plan is that you have, let's say when you start off, you have minor health issues and you've only got some cheap generic medications or nothing. And then halfway through the year, you find out, oh gosh, I now have to start taking some expensive brand name product. Well, the plan, whatever it is, has got to get you the medication. It just doesn't mean that that particular plan's got a good deal, a good buy into that medication. And yes, you get some sort of discount, but that's why you have open enrollment in the fall. The open enrollment allows you to change and add that medication in that you weren't taking before to get a much better plan that's got a better deal on that med. That's what it was all about. So yes, you have to take it on the chin for a while, basically.
Okay. Next question, what can Medicare patients do about dental and vision coverage?
Right. First of all, when it comes to vision, and people misunderstand that one, if you have a need for glaucoma treatments or cataract surgeries, in other words, anything that's medical, yes, that's covered by Medicare. What's not covered, though, is the glasses and contacts. Most of the Medicare Medigap companies, though, provide a free vision benefit through something like IMED anyway. So that's kind of like no big issue. Dental, on the other hand, you're pretty much on your own. You got to buy your own separate dental plan. And they typically will cost you, I can tell you right now, number one, they're carbon copies of each other. They're all pretty much the same. So I'd go with whatever my dentist takes. And they charge anywhere from 35 to 50 bucks. That's for sure. Oh, same thing with hearing aids. Hearing audiology, the doctor for audiology is covered by Medicare, but not the hearing aids.
So I'm going to jump to the question one down here. Any explanation for why hearing aids are excluded from coverage, even a basic model, especially considering the significant isolation and resulting depression that may result from hearing loss?
Well, that's a good question, but what they're trying to, the latest Build Back Better bill tried to build that in, tried to get that coverage, dental, vision, and hearing, including hearing aids, but it hasn't gone anywhere. It's been this way since 1965, guys. I don't know why.
Okay. Can you discuss the wisdom of keeping federal employee plan in addition to Medicare A and B? We have lots of medical costs, including drugs.
Really? Well, I guess it kind of depends upon the plan that you've got there. But the wisdom of keeping it is because of the open enrollment. I'm assuming you can change your deductibles and all that. I mean, your premiums and co-payments depending on the deductibles you choose on an open enrollment basis. That's, in other words, you can't lose anything then. You may end up paying more money if you have a lower deductible. So that might be a solution, but just getting off of that plan and you've got significant pre-existing conditions doesn't mean you can just move into a Medigap plan, because you're going to have to go, because you've been on Medicare for a while, you're going to have to go through the underwriting process, which could get you excluded. So you're probably better off with your federal plan.
Okay. A few more here. If turning 65 in March of 2023, when do you buy Part D coverage?
Sign up for your Medicare Part B coverage as much as 3 months in advance. Just sign up for Medicare, period, 3 months in advance of your birth month. So let's say your birthday is March 7th, all right? Number one, it will start then March 1. It always begins at the beginning of the year. I mean, beginning of the month. And so you can actually sign up for that then in December, January, February. It's 3 months in advance. And you can go to SSA.gov, Social Security Administration.gov. Folks, Medicare is a division of Social Security. So go to Social Security to sign up for your Medicare right there. And then it will start automatically then, in your case, March 1. Now, if your birthday is March 1, then you could be on Medicare February 1. So anybody that starts at the first of the month can start the month prior.
Okay. Okay. If you change your mailing address to your power of attorney for Medicare correspondence, which means changing your address with Social Security, what do you do about selecting Part D? Medicare now thinks you live where your mailing address is.
No,
Social
you just
Security. Go ahead.
no. You can have two separate things. You can have a mailing address and you can have a home address. It's going to be based upon your home address. So you can just give them both.
Okay. When working for the federal government, I was under the old system and only paid HIT tax. Does this make me eligible for Part A?
Honestly, I don't know. That's good. I've never heard of such a thing.
Okay. I'm 75 years old and have been covered by my husband's employer-provided health plan. I do have Part A, however. Will I pay a penalty when I sign up for Plan B at the end of 2022?
No. The reason why you will not have any kind of a penalty is because you've had a continuation of coverage through an employer's group plan. And the way you want to sign up, when you're finally getting off of that employer's plan through your husband, what you're going to do is you're going to have to fill out two forms. One form is a form that shows that you've had continuous coverage through the employer, which gets filled out by his HR department. And there's another form that you fill out that says, I want my Medicare Part B to begin at the beginning of some month. And those two forms then get filed with or sent to fax to the Social Security Administration, and they'll send you a new Medicare card with both A and B on it, and you're good to go.
Okay.
That happens all the time, by the way.
And last question, and then we'll wrap up. What is the difference between a routine physical and an annual wellness exam? An annual physical is not covered, but a wellness visit is covered. Makes sense?
Yeah, the wellness visit is a joke. Basically, they ask a lot of questions. They do just a very preliminary, you check your vitals kind of thing, but it's really not an in-depth physical. An in-depth physical means, yeah, and you'd end up having to pay for things like blood work and that kind of stuff. In which case, then, if you have a Medicare Medigap plan, it'll take care of that for you. And if you don't, then you're going to be spending a bunch of money out of pocket. So yeah, the well visit thing is not much, guys, but it's free.
Okay. Okay, well, great. Well, again, thank you, Mark. As some follow-up,
I just want to mention one thing. For those of you that might want to call my telephone number, I'll just give it to you if I could, 301-293-3617. 301-293-3617. And that's my business line. If you have any continual questions, feel free to give me a call.
That's 301-293-3617. Thank you, Mark.
Right.
I was just going to give out a different number, so that's very helpful. And your email address, is it okay to give that out, Mark?
Oh, yes, please.
Sure. So MW Trent, at Verizon.net. And in my follow-up email that I typically send out, I'll include that information again as well. So again, thank you for all that great information, Mark. Just briefly, everybody, we've got a busy April and May for our webinar series. Check out our calendar of events for all of our other webinars that we're going to be offering later today. We have our wellness series, have a number of attendees there. We're going to be talking about after the dementia diagnosis. So something, a very important topic to discuss. That's at 1:30 today. So we're double dipping today. You can, if you haven't registered yet, you can check out our website to register. Also, I'll be sending out some information about our client event on May 21st. We are back after a couple of years and we're very excited. Hope you can join us. Clients, financial advisors, people that attend our webinars, everybody's invited. It's going to be a wonderful morning and we hope that you can attend. So information will be provided about that. I think that'll cover it for today. We're running a few minutes behind, so thank you for hanging in there with us. Again, Mark, great job. Thanks as always. It's a pleasure. We'll do it again soon. So
see you, folks.
Have a great day, everybody. Have a great day, everybody, and thanks for being part of the Elville webinar series.
Thank you.
Thank you.